So far in this chapter, we've focused on diseases that can mess with your arteries. But that doesn't mean we can just forget about the veins. In this sketch, we'll dive into a condition you'll be thinking about every day on the wards: deep vein thromboses. DVTs can be fatal if they lead to pulmonary emboli, something we'll talk about in a separate sketch in the pulmonology unit. But treatment with anticoagulation can be risky too, so accurate diagnosis and judicious treatment are both essential. But fear not, we'll turn you into a bona fide DVT expert by the end of this sketch. Remember this sketch from Sketchy Path? The barricades of the June Rebellion are still the perfect metaphor for these nasty venous barricades. So we are heading back to those miserable times of revolution in the streets, where makeshift blockades and cannon blasts were a dime a dozen. DVT is one clinically significant type of venous thrombosis. When a venous thrombosis, aka blood clot in the veins, breaks off and lodges somewhere downstream, it becomes a venous thromboembolism, or VTE. VTEs in the lungs are known as pulmonary emboli. For more details on PEs, check out our sketch dedicated to them in the pulmonology unit. The vast majority of DVTs occur in the lower extremities. DVTs can occur elsewhere, like the upper extremities and renal veins, but they're much less common. The location of DVTs within the lower extremity is important, because proximal lower extremity DVTs, that is, those formed in the popliteal, femoral, and iliac veins, are much more likely to embolize and cause PEs than distal DVTs in the calf veins. That's why we've drawn these buttons popping off this rabble-rouser's coat near the proximal part of his vein pants. Gotta love the French, on the cutting edge of fashion design even during times of political upheaval and social turmoil. The pathophysiology behind all venous blood clots, DVTs included, revolves around the three components of Virchow's triad, which consists of blood stasis, endothelial injury, and hypercoagulability. Virchow's triad is represented by a recurring sketchy symbol, the three-wheeled chair, marked with a V for Virchow. For more details on the pathogenesis of DVTs, head on over to the DVT and PE sketch in Sketchy Path. From here on out, we'll focus on the clinically important details you'll need to know. Since DVTs occur most commonly in the lower extremities, we'll focus on the clinical presentation of lake DVTs in this sketch. The features of lower extremity DVT are nonspecific. In fact, many patients with DVTs are asymptomatic. When patients do have symptoms, the most common ones include unilateral leg pain, swelling, warmth, and erythema, just like what this long-suffering police inspector is experiencing. So that's why his singing was so bad in the movie. If your patient is complaining of DVT symptoms, the next step is to ask about risk factors for venous thromboembolism. Let's take some time to review these risk factors, since they'll set the stage for diagnosis and management. The easiest risk factor to spot is age. The risk of DVTs jumps by 45 and continues to increase with age. Hope you've brushed up on your history. Past medical history, that is. That's because a history of prior DVT is one of the biggest risk factors for developing another DVT. Cancer, represented by a recurring sketchy symbol, the cancer crab, is another major risk factor for DVT. Cancer creates a hypercoagulable state due to the production of substances with procoagulant activity. In a patient presenting with an unexplained DVT, make sure to perform age-appropriate cancer screenings to rule out an underlying malignancy. Whoa, is that a surgical gurney piled up in the barricade? These student rebels sure are resourceful. Kinda like med students. Anywho, let that gurney remind you that recent major surgery or trauma leads to venous stasis, which predisposes patients to DVTs. Additionally, the endothelial damage that occurs in surgery and trauma is another component of Virchow's triad, raising the risk even further. Speaking of immobilization, this is also when you should ask about extended travel, represented by that old globe tossed on the barricade. Immobilization from prolonged car rides or plane flights also creates venous stasis that increases risk for DVTs. Yikes! Trash, fires, non refrigerated shellfish? This is no place for a pregnant woman. But since she's here, let her remind you that pregnancy is a risk factor for DVTs. Pregnancy is actually considered a hypercoagulable state. Combine that with impaired lower extremity venous blood flow due to compression by the gravid uterus. And you've got two out of the three wheels of Virchow's triad. Many medical conditions are considered acquired risk factors for DVT. Nephrotic syndrome, for example, increases the risk for blood clots due to increased urinary wasting of thrombolytic proteins, especially antithrombin. At Sketchy, nephrotic syndrome is represented by the frothy yellow trash being dumped out of this kidney shaped bucket. As if our pregnant friend wasn't already having a stressful enough day. Renal vein thrombosis is a classic manifestation of VTE in nephrotic syndrome, but peripheral DVTs can also occur. Of the many causes of nephrotic syndrome, membranous glomerulopathy is the one most commonly associated with blood clots. For more on the clinical manifestations of nephrotic syndrome, head over to the nephrology chapter. Pregnancy, trauma, and malignancy are all acquired hypercoagulable states, but we also have to talk about inherited hypercoagulable states, which are big risk factors for DVTs too. There are 5 conditions you need to remember: Factor V Leiden, prothrombin gene mutation, protein C deficiency, protein S deficiency, and antithrombin deficiency. These inherited thrombophilias are represented by this funky map of Paris that looks suspiciously like a pedigree. Unfortunately, I don't think this map is going to help that lady navigate her way out of this city. If you need a refresher on these and other thrombophilias, check out our clotting disorders sketch. Don't forget about the family history. A first degree relative with a history of VTE, especially in a younger person, should raise your suspicion for inherited thrombophilia, and thus increased risk of DVT for your patient as well. Finally, make sure you know what home medications, represented by a recurring sketchy symbol, the home med bag, your patient is taking, especially if they are female. See that pregnant lady's chic French hat? Kinda looks a lot like a pack of OCPs, don't it? I bet it was made by the same avant-garde designer who made those crazy vein pants. Let that hat remind you that estrogen, whether in the form of OCPs or hormone replacement therapy, is an important cause of DVTs in women. Other medications known to increase DVT risk include tamoxifen, testosterone, bevacizumab, and systemic glucocorticoids. The evaluation of a patient with a suspected DVT is all about history. That said, you do need some objective data to work with. So let's take a look at what else you should look for to help you nail the diagnosis. The classic physical exam findings of a patient with DVT are similar to the symptoms they present with: unilateral tenderness, swelling, warmth, and erythema of the affected leg. Your attending might enjoy asking you about Homan's sign, aka calf pain on passive dorsiflexion of the foot. But in reality, it is neither sensitive nor specific enough to be used in the diagnosis of DVTs. Take that, attending. Practically speaking, if you're reasonably concerned about a DVT in your patient, the next step is to order compression Doppler ultrasonography to look for non-compressibility of the veins in the affected leg. The ultrasound is represented by the sound waves coming out of this rebel's bullhorn as he riles up the crowd, saying, "Oh, Freudian slip." Anywho, compression ultrasound is the diagnostic test of choice in patients with suspected DVT because it's sensitive, specific, and spares the patient from radiation or contrast exposure. Let's summarize the clinical presentation of DVT in a sample assessment statement. Madame Thenardier is a 40-year-old obese woman presenting with a 3-day history of right leg swelling and pain. She has no other past medical or surgical history. Her only medication is a daily oral contraceptive pill. Physical exam is notable for warmth, tenderness, and enlargement of the right leg, with associated pitting edema. Examination of the left leg is unremarkable. Given her concurrent use of OCPs, her symptoms are most concerning for a DVT. While DVTs aren't fun to have, The real reason we care about and treat them is because of their potential to embolize and become PEs. Now, those can be life threatening. Anticoagulation, represented by a recurring sketchy symbol, the container of anti-clot solution, is the mainstay of therapy for DVT and should be started immediately for anyone who doesn't have contraindications. Avoiding delays in treatment is really important since the risk of embolization is highest during the first few days after diagnosis. Note that anticoagulation for DVTs and PEs is identical. That's why our PE sketch will send you back here for review. You'll see two birds with one musket shot. Classically, we think about anticoagulation in two steps: choosing an initial agent, usually parenteral, and transitioning to a long term agent, usually oral. But as we'll see, some of the newer anticoagulant drugs are breaking all the rules. The oldest anticoagulant used today is IV unfractionated heparin, which is represented by our old friend from Sketchy Farm, the Happy Hunter. The IV on the wall next to him is there to remind you that unfractionated heparin is administered IV. IV unfractionated heparin is useful due to its quick onset and short half-life, and while other drugs have supplanted it as the initial anticoagulant in most patients, there are circumstances where it's still the best option. One of unfractionated heparin's greatest strengths is the fact that it is fully and rapidly reversible. Hence our young revolutionary, rapidly returning fire on that pesky Happy Hunter. The medication we use to reverse the effects of heparin is protamine sulfate, represented by the revolutionary's protamine protection sash. As you might expect, unfractionated heparin is often the go-to choice for any patient who might need quick reversal of anticoagulation, like someone at risk for bleeding. Specifically, unfractionated heparin is an appropriate choice for patients with hemodynamic instability, represented by this hunter falling out of the window. Those who may require urgent procedures, represented by that scalpel stuck in his chest. So that's why he fell. Classic. And large clot burden, represented by the large bird's nest in his window. Unfractionated heparin is also the initial anticoagulant of choice in patients with chronic kidney disease, represented by these rusty, dilapidated kidney-shaped pulleys, since it isn't excreted by the kidneys. Those things don't look that safe anyway. Unfractionated heparin has a highly variable dose-response relationship, requiring frequent lab monitoring with PTTs, represented by the recurring sketchy sound this busy woodpecker's making. Why that woodpecker's hammering away in the middle of a war? I don't know. The next evolution of heparin are the low molecular weight heparins, represented by our Happy Hunter's petite daughter, a low weight hunter. For most patients, subcutaneous low molecular weight heparin, such as enoxaparin and dalteparin, are preferred over unfractionated heparin. Unlike unfractionated heparin, low molecular weight heparins are administered subcutaneously. At Sketchy, that's represented by a recurring symbol for subcutaneous delivery, a mound of dirt with a shovel partially stuck into it. Compared to unfractionated heparin, low molecular weight heparin also requires less frequent dosing and has a better dose response correlation, allowing for fixed dosing without the need for lab monitoring. That's why our low weight hunter is not using these binoculars to monitor that annoying loud woodpecker. Unfractionated and low molecular weight heparins are typically used for short term anticoagulation immediately after the initial diagnosis of VTE, before transitioning to longer term agents. However, there are a few exceptions. For example, low molecular weight heparin is the anticoagulant of choice in pregnancy, as well as in the setting of malignancy. Hence the pregnant woman and this lonely crab up there on that balcony being defended by the low weight hunter. Importantly, low molecular weight heparin is the recommended treatment for the entire duration of anticoagulation in pregnancy and malignancy. So, these patients aren't transitioning to oral meds. Since blood clots are frequently treated with heparin, we will use this opportunity to delve into one of the feared complications of this treatment: heparin-induced thrombocytopenia, aka HIT. There are two types of HIT, but when your resident mentions it on the wards, they're most likely referring to type 2 HIT. the more serious life threatening immune mediated disorder that causes platelet activation and sequestration. Type 2 HIT is represented by this lonely National Guardsman holding up a broken plate against the happy hunter's gunfire. Type 2 HIT is set in motion when heparin binds platelet factor 4 on the surface of platelets, changing the conformation of the protein and causing the body to recognize the resulting complex as foreign. From there, the immune system begins targeting and destroying platelets, which is almost as much of a bummer as getting locked in prison for 19 years for stealing a loaf of bread. But how does the body destroy its own platelets? Well, let's dig down a bit deeper. As it does with any foreign substance, the immune system reacts to the presence of this quote unquote foreign heparin platelet factor 4 complex by forming an IgG autoantibody against it, also known as HIT antibody. HIT antibody is represented here by our guardsman's force shaped holster, holding his trusty IgG antibody shaped gun. These HIT antibodies bind to platelet factor 4 on the surface of platelets, which marks them for sequestration and destruction by the reticuloendothelial system. Clinically, type 2 HIT manifests with a greater than 50% drop in platelets from baseline, kinda like this plate, which is greater than 50% bloody. Importantly, the thrombocytopenia must occur at least 5 days after exposure to unfractionated or low molecular weight heparin. To help you remember, we've drawn in this bloody handprint with 5 fingers on one of the plates on the ground. Interestingly, even though the patient has thrombocytopenia, they're actually at increased risk for thrombus formation because HIT antibodies activate platelets, resulting in platelet aggregation, coagulation factor release, and clot formation, represented by this clump of hay on the ground next to those plates. A classic thrombotic manifestation of type 2 HIT is skin necrosis, especially near the abdominal injection site of low molecular weight heparins. Our National Guardsman just happens to be covered in dark splotches representing these necrotic lesions. If HIT is suspected, all heparin products must be discontinued immediately, and non heparin anticoagulation should be started. Fortunately, there are many non heparin anticoagulants which can be used. As an example, IV direct thrombin inhibitors such as argatroban and bivalirudin are often used in the inpatient setting. Speaking of non heparin anticoagulants, let's review the most important types now. In patients with a history of HIT, subcutaneous fondaparinux, an indirect factor 10A inhibitor, can be used as an alternative to unfractionated or low molecular weight heparin. At Sketchy, fondaparinux is represented by this pair of Fido foxhounds. Aw, look how well behaved they are! See how those plates in their room are still pristine and unbroken? That's to remind you that fondaparinux does not cause HIT. It's a dog eat dog world out there on the streets, but all is calm inside with these polite pups. Okay, enough sticking people with needles. Let's move on and discuss oral anticoagulants. In most patients, oral anticoagulants are preferred over IV or sub-Q agents for chronic anticoagulation. And for good reason. No one wants to be stuck with needles over and over forever. That's why we've drawn in our recurring sketchy symbol for chronicity, the grandfather clock, here on this wall. What are some of those oral anticoagulants, you ask? Well, warfarin is the OG oral anticoagulant. It's cheap, effective, and widely available. At Sketchy, it's represented by our recurring headline, War. Not that anyone here needs to be reminded of that. The one thing warfarin is not, however, is fast. Warfarin takes a few days to reach therapeutic levels. That's where the heparin bridge comes in. Typically, heparin and warfarin are started together. That way, heparin provides immediate anticoagulation, aka the bridge, kind of like the one that newsboy's running across, while warfarin works its way up to therapeutic levels. In the meantime, daily INR levels are drawn to monitor warfarin's activity. Once the INR stabilizes in a therapeutic range, typically between 2 and 3, heparin is stopped and the patient is continued on warfarin monotherapy. To help you remember, just think of this makeshift antenna with 2 veins on one side and 3 on the other. Importantly, once a stable target INR has been reached, you'll still need to monitor your patient's INR every few weeks to make sure it remains in the therapeutic range. Bummer, I know. While we have newer oral anticoagulants, which we'll cover in a moment, there are still a few reasons to start warfarin in some patients. For example, warfarin is the preferred oral anticoagulant in patients with severe renal failure because the anticoagulant's effect is monitored so closely and the dose can be easily adjusted. Warfarin is also the go to if other oral agents aren't available or are too expensive. In addition to the constant INR checks, one of the other big downsides of warfarin is a higher risk of bleeding compared to newer oral agents. That's why poor doomed Gavroche is bleeding from the gash in his back. Ugh, war is hell. Speaking of these newer oral anticoagulants, they are often called direct or novel oral anticoagulants. Direct oral anticoagulants, like factor Xa inhibitors and direct thrombin inhibitors, are the first choice for most patients. That is, those who are hemodynamically stable, not pregnant, and don't have severe kidney disease or active cancer. Hence the number one poster of this guy popping an oral pill directly into his mouth. They also don't require routine lab monitoring, which makes them super convenient. However, since most direct oral anticoagulants are relatively new, they are often much more expensive than older agents. Let's dive into these direct oral anticoagulants in a bit more detail. Direct factor Xa inhibitors, such as rivaroxaban and apixaban, have names that end with ban. So, to remind you of this, check out this Royals band poster. The word Royals is even X'd out to remind you that there's a sneaky XA in these names as well, for factor 10A. Wow, they thought of everything. Oral direct factor 10A inhibitors are special. They are the first oral anticoagulants that can be started alone, that is, without heparin, right from the beginning. That's a big deal. To help you remember, we've drawn this No Hunters Allowed poster to remind you that a heparin bridge is not needed when you're starting rivaroxaban or apixaban. Moving on, let's take a load off inside Dvt Gator Bar, where they only serve the oral direct thrombin inhibitor, dabigatran. Ah, so refreshing. Our old friend from Sketchy Farm, the Thrombeaver, is back, although this time he looks a little worse for wear. Those were hard times in France, for the working class and beavers alike. Anywho, let that dead Thrombeaver pelt remind you that dabigatran is an oral direct thrombin inhibitor. Dabigatran requires initial anticoagulation with heparin, usually low molecular weight heparin, alone for 5 days prior to starting the oral agent. Unlike with warfarin, heparin and dabigatran are not given at the same time, so this isn't a bridge. That's why we only see a glimpse of our Heppy Hunter peeking out the window of Dvt Gator. Most patients with DVTs are anticoagulated for a minimum of 3 months, but some patients are continued on anticoagulation for longer depending on the clinical circumstances and risk for ongoing clot formation. As you might imagine, there are a number of circumstances in which you do not want to anticoagulate. Let's check out this unfortunate royal sitting under that do not enter sign for the absolute contraindications to anticoagulation. Clearly, you can't anticoagulate someone who is actively bleeding. Likewise, anyone with a severe bleeding diathesis, represented by the royal's bloody nose and black eye, should also not receive anticoagulation. If your patient has recently had or is expected to have surgery with a high risk of bleeding in the near future, they also shouldn't be anticoagulated. Hence the bloody surgery scalpel in his hands. Finally, anyone who has had intracranial hemorrhage, represented by the big red feather in the royal's cap, at any point should not be given medications that will increase their risk of a brain bleed. For patients with these absolute contraindications who nevertheless need treatment for their DVT, the appropriate next step is to place an inferior vena cava filter that can catch thromboemboli before they can reach the lungs and cause a PE. The bars on this window look a lot like an IVC filter, don't they? They also happen to be great at keeping out desperate rebels trying to escape death in a losing battle. Was that too soon? Let's finish up with a review of what we've covered in this sketch. The vast majority of deep vein thromboses occur in the lower extremities. Of those, we care more about proximal leg DVTs, that is, those occupying the iliac, femoral, or popliteal veins, because they are much more likely to embolize and cause APE. DVTs classically present with unilateral leg pain, swelling, warmth, and erythema. The risk factors for DVTs revolve around Virchow's triad: venous stasis, hypercoagulability, and endothelial injury, and include old age, personal or family history of VTE, malignancy, recent surgery, pregnancy, nephrotic syndrome, inherited thrombophilias, and hormone therapy. The diagnostic test of choice for DVT is Doppler ultrasound, which identifies clots by looking for non-compressibility of the affected vein. Anticoagulation is the mainstay of therapy for DVTs, and there are a ton of options available. In general, patients are started on initial therapy in the hospital and transition later to long-term anticoagulation as an outpatient. IV unfractionated heparin is the OG anticoagulant in the hospital. It is typically given in conjunction with warfarin as a heparin bridge to provide immediate anticoagulation while you're waiting for warfarin to ramp up to therapeutic levels. Unfractionated heparin is the initial anticoagulant of choice in patients with significant kidney disease, extensive clot burden, or an anticipated need for quick reversal of anticoagulation, which you can do with protamine sulfate. Low molecular weight heparins like enoxaparin and dalteparin tend to be used more frequently in the hospital, primarily because they allow for fixed dosing without the need for any lab monitoring. Both unfractionated and low molecular weight heparins have a unique drawback: heparin-induced thrombocytopenia. The classic manifestation of type 2 HIT is a greater than 50% drop in platelets from baseline, seen at least 5 days after exposure to heparin. Even though the patient is thrombocytopenic, they're actually at high risk for thrombosis because the HIT antibody activates platelets and promotes clot formation. When HIT is a concern, you'll have to use non-heparin anticoagulants. Fortunately, we have a bunch, including fondaparinux and direct factor 10A inhibitors like rivaroxaban and apixaban. There's a lot to like about direct factor 10A inhibitors. They can be taken orally, don't require routine lab monitoring, and can be taken as monotherapy for both initial and long-term anticoagulation. The oral direct thrombin inhibitor dabigatran is also a convenient choice for long-term anticoagulation, but you'll need to start initial anticoagulation with heparin before changing over to it. Despite all the new direct oral anticoagulants, the most common long-term anticoagulant you'll see in patients will likely be warfarin, the old standby. Warfarin does require routine lab monitoring. Shoot for a target INR between 2 and 3 in most patients. There are a few pretty straightforward contraindications to anticoagulation you should be aware of, including active bleeding, a severe bleeding diathesis, recent or planned high bleeding wrist surgery, or history of intracranial hemorrhage. If your patient has any of these absolute contraindications, they'll need an IVC filter to catch any clots that may break off and embolize before they reach the lungs. See, I told you you'd be an expert on DVTs by the end of the sketch. What? I didn't warn you that you might get a bunch of dramatic musical numbers stuck in your head? Sorry, not sorry. That's it for our chapter on blood vessel disease.